practice that Mike was talking about is so important, to be able to have those strong partnerships across the community so that we can really change that environment for that mom wherever she is, wherever she's living, working, and playing. Reducing disparities, helping us really focus carefully on targeting our efforts, stable and flexible funding, of course. Communication and media, if you saw, that was a whole set of communication ads that the communities were producing, so that's going to be really a core piece in a lot of cases to counteract a lot of unhealthy messaging that we're getting in our media. Importance of surveillance, epidemiology, and evidence-based strategies with impact. So these are a couple of kind of key resources that we've developed through this funding, and going forward, lots and lots of resources. I left some up on the table. Prevention Speaks is the website where you can see a lot of videos that really are a great link to see some of these environmental strategies. Okay, thank you very much.
Come on up. Now, we are going to skip a break, but let me make a suggestion. You want to stand up and kind of move around for 1 minute? We have a lot of fantastic questions, and I want to get going with them. That was fabulous. Oh,
So you're from Virginia?
Yeah.
My husband went to James Madison. He's from Knoxville.
There you go.
He liked Mineral Point because it reminded him.
Okay, you guys, we're back down. Everybody sit down. Shall I give you 1 more minute? All right, 1 more minute. 1 more minute. This to be a dialogue, and we're ready to start the dialogue part of this. And I'm thinking I'm going to go with Skype for the first question, and that is Dr. Spong. And let's go with this. Can you speak to some of the comparative effectiveness research on obesity prevention and treatment, and how are emerging best practices being evaluated?
So it's a great question, and there clearly is a huge interest in trying to understand what best prevention methods are useful and should be implemented. I work at NICHD, and so the work that I mainly oversee is that of obesity prevention in pregnancy, or obesity interventions in pregnancy, comparing different methods, be it with technologies or groups meeting or calorie control, et cetera, looking at those different types of interventions, so comparative effectiveness interventions in pregnancy and prior to pregnancy to improve weight gain in pregnancy or to improve pregnancy outcome. I know that NIH as a whole has a lot of interest in obesity and that topic. There are trans NIH groups trying to better understand how to prevent and intervene with obesity, especially led by NIDDK and NHLBI. Unfortunately, I don't oversee those projects, so I can't speak to them specifically.
Okay, let's move on to a question for the good Dr. O'Grady. So, in the United States, interventions are considered cost-effective when they yield one quality year of life for a cost less than $100,000. Other countries use thresholds at half that amount. Why the discrepancy?
Well, there's a number of reasons for it, and typically what happens, the country that does it, most people point to that is the most clamps down on cost. Most cost conscious is the British, the UK. And so the situation there is it is about half, when you do the pounds to dollars translation. And the British are fairly committed to this. It is somewhat controversial within Britain. It's at a level that within American kind of political discussion would be considered rationing. And so the and the federal government, there is not an explicit, we're looking at costs. But the private insurers do use that rule of thumb of around $100,000. Now, part of it is unfortunately a miscommunication, I would say, or a misunderstanding between the scientific community and broader sort of political forces. So when you got into quality adjusted life here, and that sort of trickled out of what we're talking about and how that's measured, part of that is they're asking the patient a question about, if you had 20 more years to live, with the current disease you have, would you take 18 if you were disease-free, or 15? And that's sort of the initial kind of miscommunication and sort of controversy came up that we now think of as death panels. Are you willing to, will somebody at Medicare decide what's going to happen at the end of life? It's a little bit of a misunderstanding, but I don't know how much we expect people in a politically, whether they're liberal or conservative, to be sorting out through the statistics that we use in these sorts of measures. So it's a little bit of a miscommunication, but it means there's a heightened concern, there's an extra sensitivity here about to take on a standard quite as tough as the British do.
Okay. All right, Michelle, what are some specific strategies you've used in business to impact obesity while not stigmatizing employees?
That's a really great question. I spent some time working at Land's End, and I'm actually now working as a consultant to develop how do you implement worksite wellness and have it integrated into healthcare plan design to reduce healthcare costs. So I think that that's a big key, is that when it's integrated into the corporate wellness culture and it's available to everyone, then you don't have that this stigmatism of who's participating, who's not, because it's available to everyone. But I also think that as you integrate more of the wellness activities into the healthcare plan design, you'll actually get a bigger bang for what the money you're putting in, a bigger bang for your buck.
Yeah, so making the program available to everyone in an obvious fashion.
Exactly.
You think that's been pretty effective?
It has been, and actually it also increases, just people, they want to work at a place where there's a very healthy corporate wellness culture, so it attracts good workers, it keeps people there. I think it's good.
Good. To segue into a separate but related topic, this is for everyone. How can we best tackle the obesity crisis while also being sensitive to the pressures that women face related to body image and social media's unrealistic perceptions of a woman's body? For example, the new idea that big is beautiful to fight disordered eating such as anorexia and bulimia. Let me make that a little more succinct. So we're dealing with the obesity epidemic, but then when you look at the statistics regarding eating disorders in general in women, I don't know the exact number, but I think it's pretty high. It's a fine line. So again, the question is the social media body image and how women perceive their bodies. You're staring at me like I'm crazy, but I kind of get it. Can somebody word the question a little bit better? I don't know. Yes.
I'll take a stab. I'll take a stab if you want.
Okay, good.
So I think that it actually goes a little bit further in when you look at social media and you look at how women perceive what beauty is. We've gone from a culture where really super thin is considered absolutely beautiful, right? And people have really been pushing to get, and the eating disorders have fed into that, no pun intended. The problem is that nowadays there is also a push by social media that big is beautiful and that it's okay to have a tummy, it's okay to have a muffin top, it's okay to be large, which I don't want people to think it's not okay. You need to be comfortable with who you are, but we need to grasp as a society with what the implications are of the different extremes in weight. So it's not just how you look, it's how that weight translates into health, not only for you, but for your family.
Oh, I like that. I feel like that should be an advertisement. In the back.
I just have a story, a short story. I have a niece who's 32 years old, but when she was 14, somebody told her she was really fat, which
Let me turn that question right over to, I'm thinking the two women in the middle. Help me out here.
Well, what I find in the clinic setting, as I said before, is mother's body image is strongly associated with the daughter's body image. And I myself struggled with anorexia in college, and actually that was one of the reasons I didn't want to go into nutrition in the first place, because I thought, oh, I'm obsessed with this. I don't want to be, get into this. But what I realized as a parent was, before I even started having children, was, wow, I need to get control of this and really take control, because otherwise I'm going to pass this on to my daughter. So I think really working with parents, and I think there's also a relationship between the father's relationship and the child as well, that has to do with body image. So it's not just working with the child, it's really working with the family as a whole, and also realizing that in a setting, a lot of times it's not necessarily about food, it's about something psychological and emotional, and that counseling is really an important component of that.
The other thing that we need to actually be very careful with, big is beautiful, but we're not talking about weight, we're talking about health, and you need to distinguish the two, and I think oftentimes we miss that point. You can have a higher body weight and still be healthy, and so we need to start talking in terms of health and stop stigmatizing people either way, because I just want you to be healthy. And so if we can get society to start talking in terms of health rather than weight, we can help young women stop being so obsessed and feeding into eating disorders.
And there is tremendous pressure. Everybody in this room knows that. I have a daughter. When she was a young teen, it was like, and I can't recount all the ways I learned this. They were somewhat subtle, but the pressure that she felt. And it was a family project. She was a little chubby when she was a teenager. Like mother, like daughter, what the heck, I don't know. But anyway, there's a relationship there that, and we've said this in a variety of ways, the parental role with that, and I like what Chanel just said, focusing on the health, not the weight, I think is a really great thing. Now, Chanel, I'm thinking if you could talk for a minute about this concept of getting the healthy weight thought going prior to pregnancy. Do you have any thoughts on that, how we might do that, or?
I think a lot of this is something we need to stress in medical school. Oftentimes, it's too late when they get to me. This needs to be something that's in pediatric offices, family practice offices, nurse practitioners, midwives. We need to start addressing women when they are much younger than their what we consider reproductive age. The healthier you are overall, the better pregnancy outcome you're going to have. And there are things that you can do to alter your pregnancy trajectory. I have seen an increase in preconceptual counseling, which we're very happy to do, where I sit down with women because some doctors aren't comfortable having the weight discussion, and so you send them to me and then I have the weight discussion. And I usually start it off and say, I understand the hand-to-mouth disease. I happen to like chocolate chip cookies, so I'm not judging you, but I'm telling you what your weight, how your weight will impact your pregnancy and all the complications that you may see during pregnancy if we don't do something to address your weight, and what it could how it could impact your child's long-term health. And so just a 10% weight reduction can go an extremely long way to improving your pregnancy outcomes. And that's pretty achievable with small steps. And so I think it's something we need to start talking about earlier. It's much better if you do it before you get to me. Happy to do it preconceptually, but I think pediatricians need to kind of take up this mantle before women even get to that point, because like I said before, their infertility rates are higher in women who are obese, and you can decrease your need for expensive reproductive technology, whether it's pills or infertility, in vitro fertilization. You can bypass a lot of that with just a 10% weight loss and increase your ovulation. And people don't talk about that because no one wants to talk about weight, because it's a touchy subject. You remember that scale. So.
Now I've got a question to go to the entire panel here. how do we find a balance between personal and social responsibility for making healthy choices and impacting rates of obesity? The personal responsibility and the social responsibility. For example, Mayor Bloomberg recently banned soft drinks greater than 16 ounces. How do we find a balance between regulating our consumers' private purchases and creating that environment for people to make healthy choices?
So as a New Yorker first,
Oh my
I
God.
have to defend Mayor Bloomberg. He didn't ban 64-ounce drinks. He banned you consuming the 64-ounce drink in one sitting. If you want to get back up and get that refill, feel free to go do it, but be conscious of how much you're consuming, because now you have to get up from the table and go get another refill. And a lot of what Weight Watchers and those types of programs that have been demonstrated to be very successful do is to make you aware of what you're putting in your mouth. Because much of what we do is we sit in front of a TV and we eat, we're on the go, we're eating while we're running, and no one realizes how much you're putting in your mouth. And if you just slow down just a little bit, you might not actually go get the second drink. So it's right on the side. You can still do it in the privacy of McDonald's or wherever you are. But you got to make a little more effort. Maybe get a little exercise as you go to refill your
You gotta
drink.
love the New Yorker thing. But that's a good example of the personal and where we as a society might intervene. Do we have any other comments? Mike?
Yeah, I think that there's a couple of things, and I'm not sure that I would sign on to Mayor Bloomberg. The sort of, there's going to be a concern about nanny state and sort of you have to eat your broccoli coming out of Washington and things like that. So I'm a little concerned about that, but I can see the way the pressures are building and the incentives are going. And now I tend to look at it from how you pay for these things. But if you remember, one of my slides had kind of where were these dollars coming from, and it was disproportionately out of what was called commercial insurance. So that's really employers. It's in Medicare, it's in Medicaid, but employers see the brunt of this. And so what we've seen up to this point is a series of measures. It's sort of been more carrot than stick. But there are some changes that are coming that if this continues along these lines, I would predict that you'll start to see employers saying, the same way that they were thinking that they wanted to charge smokers higher health insurance premiums, as you saw in the other presentations, these lines are crossing. So I think you will see, and in part of healthcare reform was a thing that allowed a little bit more differentiation, up to a 20% differentiation in premiums. So you're going to see, I would argue, first it'll come positive. First it'll be pitched as a kind of the healthcare good drivers discount, a healthy discount on your health insurance. But I can see over time this is saying that if you're, that you are a higher risk, you're, when you talk about the interaction between individual and social, and therefore you can keep doing what you're doing, but you're going to pay 15% more because you're asking your coworkers to subsidize you in something that we all agree is unhealthy behavior. So it's not going to be as pleasant. It's not going to have the smile to it as much. And then the other thing I think you'll see again from the employers is some of the things we've seen them do are also in education, where they'll pay for the college course. But if you get an A, it's 100%. If you get a B, they only pay 80%. If you get a C, they'll pay 60. If you get below a C, they don't pay for it. So I think you'll see that if you want, if you'd like that kind of Weight Watchers equivalent, that's true. But they'll probably only reimburse you if you actually hit the target. And they may only reimburse you part of it, and then they'll reimburse the rest if you're still at the target after 6 months. So it's not as polite a discussion. There's no doubt about it.
Reform is coming. Susan, I can tell you want to say something.
Well, there is tremendous pressure to overconsume, as Kathy's first slide showed the portion sizes of products. I think even the question about how to have that conversation with women, I think that women, if you direct them to think about the environmental pressures that they face, the bombardment, along with the lack of access to affordable, healthy foods. I stopped in our USDA office in a little county up in Wood County, the center of agricultural Wisconsin, and said, we're working on this obesity project. You're working with these farmers. You're growing this food. And they said, we don't grow food for human consumption here. that's not what we do. So you think about what our food system has become in this country, and you talk about economics. Our farm to school program is reinvesting money to really support the growth of healthy food within the community and build that capacity. We only make 2 to 3% of our what we're growing in this stage is fruit and vegetable consumption, food for human consumption. So there's other economic factors, I think, to put in the mix here to really build a healthy community. So I think that our schools and our child care centers are certainly places that we want to begin, where we really want to have healthy food and healthy beverages. What we know from lots of research that's the healthy foods that we want to have for our children. And I think in a lot of adult settings, we're going to want to have that too, more and more.
Can I do just one quick add-on to what Suzanne said? Because it reminded me of something. And I think this is sort of indicative. I hope it's indicative of where we're moving. But it's important to think about who you're talking to and how you move this forward. So when you were talking about kind of the USDA, so we have a school lunch, we have a school breakfast program. For years, originally it was just price supports, kind of an crop insurance sort of linked thing. It transitioned then to food security. You were fighting hunger. And they still tend to think that way. They don't really think of that program, or they're starting to change. I don't want to pick on them. Right. But it's not really a public health program. It was more like a food welfare program for many decades. And so, you'd see the big block, we all went through, well, not all of us, I'm sure, but, the public school with the macaroni and cheese, and then the cheese on this and the cheese on, and I've been in Wisconsin and I understand, but it's sort of, but that was sort of because that was how they made sure you hit at least a certain number of calories. As they have to transition out of, this is not, certainly they have to keep their responsibility for food security, but it's important what foods you're eating, not just that you're having, an extra meal. It's that you get a good meal at school. You get a good, school breakfast, good school lunch, especially for the low-income population that are particularly vulnerable to these things. So if they can mobilize and change their thinking, that you're sure that at least during the school year you're getting 2 healthy meals. Whether they trade it for French fries, that's a different question. But at least, especially that target population, who are the folks who go back to food deserts and go back to, these sort of situations. So if you're able to mobilize and coordinate your sort of the way people look at this thing, people who traditionally haven't taken up this cause, and if they just are a little smarter about it, I think it could be very helpful.
Well said. Mike, you mentioned one approach that healthcare reform might take in terms of obesity management, which means more of a stick, less of a carrot. Kathy, I'm just wondering if you have anything to add to this in terms of what's coming down the track with possible healthcare reform models. Uh-oh. Kathy?
Say again?
I'm just wondering if you could make a comment about the relationship between healthcare reform or new models and healthcare delivery impacting on obesity.
I wish I could. I wish I knew how healthcare reform is going to really roll out and transition and allow us to improve healthcare for women, children, families, all of us. I don't think any of us really know exactly how that's going to happen. So
it's a black box. Thank you for your honesty. I like that. That goes a long way.
It's a black box,
It's
but it's very encouraging because there are going to
Be millions of people who now have access to physicians who didn't have access before, and so maybe they'll at least start the conversation, which they weren't having previously. So let's not be totally pessimistic.
Yeah. And actually, in the worksite wellness setting, healthcare reform really has some great incentives. Right now, you talked about there being a 20% differential for premiums, but in 2014, I believe that goes up to 30%. So they're going to increase it so that you can continue to give more of a carrot to really incent more worksite wellness.
And I want to say, I feel optimistic. I mean, the point I was trying to make was that, look, healthcare reform, we're not sure what that's going to look like. But I agree with Chanel. more people with health insurance equals more opportunity to proactively deal with obesity. I think that's a fair statement.
Yeah. The only thing, just to clarify, the only thing I wanted to say there is before employers could not differentiate between subpopulation of their employees. Healthcare reform is part of it, not exchanges or any of that, said that they could start to do that. Now, step one of that is a good driver discount for people who do healthy behaviors. And if that gets the job done, great. But you have to know those employers are thinking, if you now tell me I can charge somebody 20% less, that also means that legally now I can charge somebody 20% more.
Right.
And so that's they're not there yet, but you have to, but what we see, I tend to look at Massachusetts as sort of our bellwether of where it may be going. They got everybody covered. They have a lot of very good health outcomes from it, but all of a sudden now they're turning and seeing it's way more expensive than they thought it was going to be. So now they're trying to pass laws that say hospital growth rates can't be more than X, and that's, boy, talk about trying to herd cats. That's really hard to do. So it just means that as money gets tighter, you're not going to have the resources to sort of do the more positive kind of, we'll just give you a grant and we'll hope people do the right thing. That kind of other side of things is just, you can see where they're going to be under pressures over time.
Well said. Well said. Okay, this is for all the panelists. If so many people in poverty are overweight, is there something wrong with the food assistance programs or food stamps and what is covered? Should more fruits and vegetables be allowed and fewer processed items? That's a low ball, guys. Go, take it.
Well, I'm torn on this because the knee-jerk reaction is yes, but then you have to talk about the food desert. And so these women don't have access to the grocery store with the healthy fruits and vegetables. So if we unilaterally say, you have to buy more fruits and vegetables, but then don't give you a way to get there, that's penalizing them. So I think we need to address some things before we make that statement. And I'll leave it at that.
And I hope we do both at the same time. So, there are really wonderful initiatives going on that I didn't have a chance to talk about introducing more fruits and vegetables. We've got a great new truck in Wisconsin, in Madison, that you probably have seen on the news that's making inroads into communities that are food deserts right here in Madison. We're working with convenience stores to introduce and provide resources to have more healthy food. I think we need to do both in a considerable way.
Mm-hmm.
And I would agree, increasing the access to those foods is really important, because if you look at even if you were on food assistance and they say, you should be, you see all this literature that says, okay, you can make all these healthy meals on $23 a week for a family. But then you have to start considering too the time that it takes to prep that. So if you're taking dried beans, you have to soak them overnight. One recent research article I just read said that on that $23 a week budget, you can have a really nutritious meals for the week for your family, but it's going to take you 19 hours to prepare that. And with more women working outside the home, on average, most women spend less than 6 hours preparing meals at their home. So I think there's a little bit of, just the reality of it is not always there.
And then we have to also consider that, I'm sorry.
We do need more access. I agree with that, but I also feel that a lot of those women or families don't know what to do with the vegetables.
It's true.
They don't know eating these vegetables. They don't know how to prepare them. It doesn't have to take long. It doesn't have to take long to prepare them. And I don't know how to get around that.
That's like a cooking lesson.
Cooking classes.
Yeah.
How to storage.
Yeah, because if you give somebody a raw beet, I don't eat raw beets.
Something takes a few minutes.
Right,
You can
right.
put the potato in the microwave. But I think that's a problem too. They don't know how to cook these things. They don't know how to keep them from rotting in 2 days. And and it's too bad when the kids grow up without these vegetables, and then when they're parents, they don't know. I mean, they don't know.
Right.
We also have to
It's
be a
easier to
little.
buy something already prepared since they don't know how to.
I think that's
Okay,
as long as
Kathy,
it-
jump in here.
I want to echo what everyone said. I completely agree. you need to improve access, but you also have to change the culture. It is so much easier to go and get a lot of food on a $1 menu, right? Yes, you can, if you improve access and get access to fruits and vegetables and even teach people how to use them and prepare them quickly, it still requires a whole change of culture and what is good to the family, to the person, what is rewarding, what is comfort food. So it's more than just having access, it's wanting that access and having the ability to utilize that access and making that be something that people want.
Thank you.
It's so complex.
In the back.
Yeah, a little bit related, but I have been listening, and we haven't yet touched on the issues of racial disparities. And Latino kids have the #1 in obesity. And what are we doing to address that? What are we doing to address all the other health disparities? I was very puzzled by the idea that you mentioned of parenting and how if you're more directive that could go against it. And my mom loved the comment because I'm very directive with the kids at home, and so far it's going really well. We have the rules. Those are the rules. You have to eat your fruits and your vegetables, and then you might have one candy, you know. And I think it's going well. So I was surprised by what you say, because also I'm a physician, I'm a family medicine doctor, and 90% of my patients are Latinos, and I have a lot of kids that I'm trying to help with obesity. And what I have seen in the families is that actually parents have gave up, basically. They don't want to tell the kids what to do. The kids are actually doing and saying what they want. And when you have a 10-year-old that the mother is saying that when they go shopping, they basically threw a tantrum, and that's why they buy whatever they want so that they don't have to deal with it, there's something wrong. So I think that definitely is important how you be directive and not forcing kids into doing things. But I think parents are losing track of what is going on with their kids' lives. Particularly for Latinos, what is happening is before we used to have mom or grandma that will stay with the kids. Now we don't have anybody that actually cooks at home or that is with the kids. The kids are doing whatever they want. It's easier to connect them to the TV than it is to go out and do something with them because we don't have time. And it's easier to reward them with chocolates and games and whatever else because now we are not with them and we feel guilty because we are not with them. So if you could comment a little bit more on the parenting, because again, I was puzzled because what I'm doing with my families is saying, regain the power. You are the parent. The 3-year-old, the 4-year-old cannot go out and go to McDonald's and buy what they want. And when you go out, you can tell them what the healthy choices are and give them choices, but give them healthy choices. So I think, again, in general, as parents, we are losing ground with kids because we are too tired and we just don't want to deal with it.
I think you said it perfectly. I think when I was talking about the parenting style and someone being very more like a dictator, I was thinking more of the parent that as a child's eating, as young children, we know how much food we need to eat. It's just kind of intrinsically in us. And we know when to stop and we know when we don't need to eat. So I'm thinking of like a toddler in particular when they're more of a grazer and where the parent is like, no, you will sit at this table and you will eat everything on your plate before you leave. Instead of what you're talking about is, offering them healthy choices. You are the parent, you've made the decision of what the healthy choices are gonna be, but then you let the child choose. So I didn't mean that because what you've said is exactly what I experience with my families, is that most of the parents, it's parenting skills that they lack and the energy to actually reinforce. A lot of our clients are Latinos, and they say the exact same things that you're saying, is that, typically it was more of a matriarchal society in their family where the mother or the grandmother was at home cooking, but now the mother is working very long hours. And those are some of the things that I hear from those children that I work with, that they are at home alone. Their, maybe older brother is who cooks for them, that their parents don't want them to go outside. They're afraid of the police. They're afraid of their safety areas. So I think you bring up an excellent point. And again, I apologize if it came off that I was saying that you shouldn't have any control. As a parent, you have the control. You have the control to offer those healthy choices. I think that's incredibly important, but not in a way that's critical or unconstructive to your kids. I think that's where the research is coming from, is that just not being critical and really overanalyzing everything your kid eats is really what has led to increased BMIs.
And I think this is another area of education. We were talking about how to, educate individuals about cooking. And then the next part of this is educating parents and families about issues around food and control in general. But I think the point we were talking about a few minutes ago regarding personal and social responsibility is at the heart of that. I have a question here for Chanel. Have there been studies done regarding types of foods women eat during pregnancy affecting food preferences of children? For example, pregnant women crave salty food. Does the child want salty food in the future? What are the findings of that?
There really haven't been any studies about that, but there have been lots of anecdotal reports from moms. So,
yeah, everybody's giggling. I have my own little story. In the back?
I'm sorry, I'm not responding to the present question, but the last one that we had talked about. I am a mother of 3 and was divorced and raised my 3 children while going to school and working 2 jobs. But I found the time when I wasn't working to make my meals ahead of time and then put them in the freezer. Even things like, and my children will not go to anything that has chowder anymore. But even at this age, but any kind of leftover vegetables I would put in the freezer and then make soups constantly, and then freeze the soup, whatever we didn't want that particular time. Right now I'm working as a volunteer in a food pantry, and because I've had the experience, really recommend to the clients, we offer so much macaroni and cheese that, okay, take this and then mix it with the macaroni and cheese, or take more vegetables and less macaroni and cheese, or you can make your own egg McMuffin, use the egg and the ground beef, or I know in our particular circumstance it's like bologna or salami, but the children really identify with those egg McMuffins. They're getting their protein with the eggs, and bread is always offered. I just find that if you can, in my case, initiate some recipes, or to say, rather than doing this alone, you can add this and this and this and do something more creative, and then get those vegetables in there and fruits in there. The people have been very, very receptive, saying, I never thought of that, or, oh, that's what you do. And soups are so nutritious, and they're so easy to make that, like I said, when I had time off, that's what I did. Let the soups cool, put them in a freezer bag, put them in the freezer, and then they were available. And as my children got older, once a week, each child was responsible for making a meal. I had one son that just pulled things out of the freezer that were already made, but at least they got the nutrition, key as far as doing things and doing them right.
Yeah, thank you. Another educational opportunity for society at large. This question is for Susan. So, how will the positive results of the Wisconsin community projects be disseminated to the rest of the state?
Oh, we're working on that so hard. I wanted to, we're packaging up some of those resources. I think the Farm to School project is a great illustration of a lot of what you're talking about. and also the mom who feels that the kids are, out of control. Part of Farm to School is a program called Harvest of the Month. So there's a whole set of educational resources. So the children are learning about these healthy foods. You saw, the chef introducing the kids to those healthy foods at school, and then they're learning about how to cook them, and then those resources are also coming home to the parents. So I think my vision, when I was talking about vision, was a Wisconsin Kids Cook program, so that we really could celebrate and have kids actually bring some of that nutritional learning home. And so I think also what you were speaking of, it's really important that we have the settings that your children are spending time in reinforcing the same messages that you're trying to teach them at home. So, again, those kind of core settings. So we're packaging up those videos on Prevention Speaks. So that's a really great learning tool to really hear about what communities are doing. We're packaging up all the steps to complete streets and Farm to School. A lot of the panelists and helping us really look at the evaluation and really get focused on what have we done that's really making a difference and sticking. And so we'll be presenting that all back in written resources.
Fabulous. Fabulous. Sounds fabulous. Over there?
Yeah, I have a comment or, get this. I have a comment or a question, because two slides are sticking out in my mind as we go through all these steps. I mean, they were all great presentations, but two things that I think we haven't talked about enough or addressed. There was a slide on all the multifactorial reasons for obesity, which were tremendous, and I think we all know those. And then the other was, I think you referred to it as I wrote it down, the pyramid of opportunities where you can do interventions. And at the top was the health and education, the educational stuff. And at the bottom, I think, was the socioeconomic and so forth. And I work as a nurse in the community, as I'm a parish nurse, and I've been in community health for 40 years now. And it seems to me that we've done a lot of that education, over the years in different ways. And of course, there's always new ways to address things and new motivators. But it seems to me that there's this basic behavioral, deep down thing that makes people, respond to want to make a change. Whether you call that like a spiritual thing, a desire to improve yourself, a recognition that you deserve to feel better, to feel healthier rather than just look pretty, whatever that is. And I'd like your comments on how that fits into community planning, which we're kind of talking about here, and also the piece about, the healthcare reform, and you talked about the economics. Okay, if you can stick to Weight Watchers, you get a discount or whatever. I'd like your comments on that. Thank you.
Well, I think that what I'm excited about when I look at what communities that really have devoted significant time and resources and really come together as a community and really looked at the health impact and really embraced the idea that we want our children to be healthier in the future, that we see that we're on a bad road, we're on a bad path, and we really need to come together to make sure that our children are going to be healthier in the future. And I think mothers, fathers, and business leaders can really come together around trying to make that change, so that we're really wrapping an umbrella around our children of healthy food and healthy opportunities to be physically active, so that we can really make a change and change those trajectories that Michael is showing us.
So one of the things that I find is an area that most people don't argue with each other about is how much they love their children. And so that can be a powerful motivating tool. And so when we are honest with women about what their weight is doing to their reproductive risk and their pregnancy risk and what those risks do to their children long term, I find that women actually do get motivated. So while they weren't motivated previously, they become extraordinarily motivated to improve both their health and their children's health. And so pregnancy is a wonderful time because, one, I have a captive audience for 9 months. Can't run, you can try, but you can't hide. And so that's a great place to start it, but if we all start that conversation, and a lot of women, at least when we're little girls, aspire to have children, while that changes over the course of time, if we start talking about health and obesity, the health of your long-term family overall, I think we can motivate the change in women overall, and not just our children. We can do it as a group, because let's face it, men go to the doctor because of their wives and significant others and their mothers. So we have control over that aspect as well. And so we can really make a huge impact just through working with women. If we can't get everybody in the office, we can make huge impacts with just getting women in the office.
I want to second that. This thing about the love of your children. It is a spiritual thing. It's a spiritual thing and a very powerful motivator. And Chanel, she does have a captive audience for 9 months, actually much longer than that.
Can I just follow up on one
Yeah.
of those? Because Chantal did a really nice job here before when she did her slides. So, I mean, it's much of what when we think of public health is trying to be nice about these issues and sort of encourage people along. But she was quite clear. There was no happy talk in, your gestational diabetes, it was sort of clear. And I think to a certain degree when we think of these things, and if we're gonna get to the bottom line here, it's not just the obesity, it is things like type 2 diabetes. And as that's become more and more common, there's a little bit of a soft selling of that. That is a horrible disease, and you die badly, and can really destroy your family with this long, painful end. And to kind of soft sell these things because they don't want to upset the patient is kidding them. No, they're going to go blind. No, they're going to be on dialysis. It's bad. It's sort of, I mean, I don't want to be the scared straight guy, but at some point you have to give people the real facts, not the way we would like life to be.
I don't soft sell for the pre-conceptual counseling. And I often tell women, I say, I love women, I love my job. And so my job is to make sure you're healthy. My job isn't to sit here and make this sound the way you want me to make it sound. I need to tell you the truth because you're a big girl and you can do this, and I'm here to help you do it. But I need you first to understand why I need you to do it. And so I don't do the soft sell. The way I sold it today is the way I sell it in the office.
Right. Listen, we're coming to the end, so I want to wrap up with one more question, and here we go. 3 distinct action areas. First of all, building knowledge about what to eat and what to do, developing skills with how to prep food and think about education in general, and ensuring resources to access good choices. In terms of those 3 areas, what, if any, role does law reform play in advancing these areas? Are there, or are we really just stuck in the present mindset? So again, we're going back to accountable care and healthcare reform. That's what we're going to wrap up with, because that is a big train coming down the track. Do you see opportunity with healthcare reform in a more robust fashion affecting education and resources? We've danced around that a little bit. Mike, you talked about the carrot and the stick. Are there any generic comments, or are there any comments from the audience regarding that specific question?
I can go again first if you'd like. I mean, I think there's a lot of opportunities there. I think you will see those sort of things. I think the third part, though, the notion that just stepping away for a second and just thinking federal budget policy, the idea that there's going to be, we'll just get a CDC grant and run with this, I think that's yesterday, not tomorrow. I just don't see those people having those kind of resources going in the future. So to a certain degree, that sort of should motivate us now. While those resources, before they go away or get shrunk to half what they are now, it's if you've got a good idea and you think it's going to make a real change, it's time to go.
Okay. I want to wrap up by asking each member of our panel, what is the one thing that our audience members should take away from today and begin to incorporate into their work? And Kathy, I'm going to start with you.
No one prepped me for this. I think the thing to take home today is that obesity clearly is a public health problem. We have steps that we can use to try to mitigate that problem, and such as we need to lead by example. We need to eat and walk the walk and talk the talk and do what we need to do to show others what they do, what they should do. But that we also have a really complex problem on our hands, and that we need to really try to identify small steps that are going to make a large difference.
I like it. Have some further comments from the panel? Or has she succinctly summarized this? It was a pretty darn good summary. I don't think we need to repeat that. Kathy, well done. And I know that you have a meeting at 11. Thank you so much. Let's give her a round of applause. So let's talk about next steps. Thinking about a white paper to be written from this conference. Please sign up at the registration table if you want to receive a copy of that. We will be doing that. In the Department of OBGYN, we have an advisory council. We have several members here. We're going to focus specifically on obesity in the next 2 to 4 years. And I would encourage everyone here to identify something you can do to move the issue forward. Speaking of that, we're going to have a networking opportunity here, and we've identified 3 areas to think about in terms of that. Number 1, mobilizing communities and partners, looking at the physical environment and transforming that. Number 2, reproductive health impacts, preconception, pregnancy, postpartum, breastfeeding. Chanel, you're obviously going to run that. Susan and Michelle, I'm looking at you for number 1 to go to the number 1 networking table. And then number 3, the economics, cost savings versus benefits of how to make the case for investing in health plans, insurance companies, and policymakers to fight obesity. Before we break up and go to our networking tables, and I'm looking at Lizette for directions in terms of that, I want to say thank you. This has been a fabulous audience, and I want to say thank you to the panelists. I mean, I found this fascinating, and I learned a lot. Thank you very much.
Thank you.
So Lizette, where are the 3 tables? Because you guys get to choose which one of those 3 tables, networking topics, you want to schmooze over. One there.
One where you were sitting.
Okay, so number 2 will be Chanel with reproductive health issues. Number 1 over there is Susan and Michelle. And then table 3?
To the right of the, to the left of the screen.
Right over here. So please stay. This is like a really good part of it. You get to talk to people you don't know about a topic that's really interesting. You wouldn't be here if you weren't interested. And I want to say thanks again. I really appreciate your attention.